Okay, thanks for coming to the second segment of this webinar on CVAD, which is Central Vascular Access Devices. And again, we welcome back Ms. Ho Swet Lee, who is actually a key, what's the term that you would like to use?
Oncology nurse.
Okay, oncology nurse, but of course she's one of the top oncology nurses, trained and has been one for 20 years, and now she has gone into hospital administration, training, okay, which is really her passion. Training is really her passion. So without further ado, Swet Lee, maybe you'd like to join us and show us your slides, and go ahead.
Okay, good evening, everyone. As all of you know, today is part 2 for the Central Vascular Access Device care. As hope all of you did join my first session, so that you got at least the fundamental understanding about types of CVAD, and then the structure of the CVAD, so that you can continue to go into what are the common, then you can understand better why you might have such complication. Then only we look into the sign and symptom of the complication. Of course, prevention always better than cure. Then how to prevent all these CVAD complication, and if it's really already happened, then what are the troubleshooting measures that as a nurse that we can at least try, and before we give up on the CVAD or go for other intervention or medication treatment. Okay, I listed out a few common complications related to CVAD, which is occlusion, torn damaged line, infection, air embolism, thrombosis, catheter tip migration or malposition, mechanical fibrillaritis. Let's go through one by one, yeah? You may stop me anytime if I go too fast, because the group is not that huge, right? Okay, we start with withdrawal occlusion. Usually what you will experience, the sign and symptom of withdrawal occlusion is when you try to flush, you are able to flush in your normal line, okay, but unable to aspirate blood backflow. Okay, as all of you know, before we want to use the CVAD, attempt to do anything, the first step is we have to aspirate. The aspiration, the sign of a backflow, is the indication for us, yes, the CVAD is in good condition, safe to use, then only we can flush in whatever we want subsequently. But withdrawal occlusion happens when you're able to flush but unable to aspirate blood. Sometimes you also encounter, even you wish to flush also, unable to push in. Neither aspirate blood backflow, or a bit resistant to push in, resistant and hard to aspirate, and when you hang up a saline and you let it free flow, then you observe the slow flow rate of the intravenous infusion. So all these are the sign of some occlusion is happening, okay? There are two common types of occlusion. First is the thrombotic occlusion, which might caused by fibrin-shaped intraluminal clot, neurothrombosis, venous thrombosis. As incident pickup is about 58% of catheter occlusion is caused by formation of thrombus within or around device or within the surrounding vessel. There are also another cause is due to non-thrombotic occlusion, not related to blood clot, okay? 42% of catheter occlusion caused by drug or mineral precipitates or lipid residual from such as TPN, okay? This could happen like if you infuse incompatible drugs together into the same line, okay? They might crystallize and they might have some mineral precipitates. So how to prevent occlusion to your CVAD? The most crucial, as I mentioned in the first session, is not what solution you use to flush. The most crucial is your correct flushing technique, okay? You have to correct flushing after each use of CVAD and after blood transfusion, blood sampling, okay? You can use a positive pressure bunk. Never use incompatible drugs together into the same line. If you got double lumen, please use different lumen from these two incompatible drugs. Do not infuse like Y-side or piggyback concurrently two incompatible drugs into the same lumen. Okay, then you have to flush and rinse all residue with normal saline between each medication. If you're hanging drugs A followed by drugs B and drugs C, please make sure in between drugs A and drugs B, you hang up a normal saline, at least run 50 to 100 ml to rinse off the drug A before you hang up the drug B. Always watch for early signs that indicate an occlusion, such as resistance of blood return, inability or sluggy flow to infuse, or increased resistance to flushing. So when all these early signs of occlusion happen, then you will practice the troubleshooting measure later that I will share with you, okay? Or even you can attempt to flush more. Not necessarily rigidly like stick to I only flush with 10 ml normal saline followed by 5 ml Hepcel. No, if you realize there's early sign of occlusion, you even can flush with 20 ml normal saline, 30 ml normal saline with your syringes. Okay, no need to only stick to 10 ml. Go ahead with more normal saline until you feel the sign of early occlusion being released, okay? You also have to inform the patient, okay? Especially patients with those CVAD where their catheter are transparent, like their neckline, their non-tunneled catheter, yeah? Some the jugular line or subclavian line, the catheter are transparent, right? So if the patient saw there's blood refluxes in the catheter, it means already got some blood enter the catheter. It could be improper clamping the catheter. This usually happen to open-ended catheter, right? So they need to come back to have a proper flushing with turbulent flushing, push-pause technique, positive flow, and get it clamped and make sure the catheter is clear without any blood stain there. Because if you leave the blood stain long enough, it will become thrombosed, okay? And it will clot and block the catheter. So this is the flushing technique that, okay, this is when you should flush, okay? Flushing is necessary before starting a treatment, okay? So as I said, before you want to use the CVAD, you must first step, check backflow. If got backflow, then you need to flush with normal saline, okay? After you flush with normal saline, then only you start your treatment, whatever treatment, antibiotic or whatever chemotherapy, all right? After each treatment, changing infusion solution or in between drugs, okay? Or you are removing your non-coring needle, especially for chemopod. Or besides removing needle, of course, it's end of the treatment if you are using a PICC or tunnel or non-tunnel line, okay? And lastly is the maintenance flushing. So this is these few points is guiding us when you should flush. Okay, maintenance flushing also different CVAD, different frequency. Like if you're using the non-tunneled line and the non-tunneled line, like neckline, jugular line, all right. This you have to flush every day, okay? And if you are using tunneled line and PICC, the patient is having tunneled line and PICC but not in use, then the maintenance flushing should be carried out every week. That means the patient do not have chemo for a few months, but every week the patient have to do the flushing for PICC and tunneled line. It should be done weekly. If it's a pot, implanted pot, or you like to call chemo pot, right? Then the maintenance flushing at least 4 to 6 weeks. But I also saw some latest research mention there's no significant different risk of occlusion between 4 to 6 weeks and others. And the research compare with 3 monthly. So there are more research yet to come up to prove that 3 monthly is safe lah. Okay, but so far most of the research guide us the pot should be perform the maintenance flushing 4 to 6 weekly. Flushing technique, as I emphasized in also during our first session, this is very crucial to prevent occlusion, the technique of flushing. Okay, you should perform turbulent flushing or push stop technique, okay, followed by positive pressure, then disconnect or clamp. Okay, those who missed the first session, I repeat the video because this is the crucial skills to prevent occlusion to your CVAD. So pay attention to the video. Okay, push, pause, followed by positive flow, clamp immediately. Okay, this is the correct flushing technique to prevent occlusion. What if occlusion already happened? So the troubleshooting, what can you do if already happened occlusion? You unable to aspirate blood or you unable to push in saline. It's very high resistance. So you can, first step, please check for any sign of mechanical kinking. Is it due to, especially the tunneled line? You've got a long catheter that hanging at the chest. So make sure you do not have any kinking part that hidden, covered by gauze or whatever. Then you thought is occlusion, then you do all the things, but actually is the catheter part is kinked. Okay. Second, try to reposition the patient. You will observe some of your senior will ask the patient, stand up, turn the neck, move the arm, twist the chest, or moving the shoulder back, all this. So try to reposition the patient. Thirdly, you can attempt to flush the CVAD with about 3 to 4 ml normal saline, only normal saline, not other solution, yeah, using a positive pressure technique. Okay. Then if blood return still not possible, then you want to try to apply little pressure, but no forceful pressure, yeah? So you use the bigger syringe, which is, you can try 20 ml syringe, and then you fill the syringe with 15 ml normal saline. You leave some space behind. Then you use the push-pull method, okay? Push a bit, pull back. Push a bit, pull back, push a bit, pull back. So try to push the saline and pull, apply pressure, suction, and hope this will release the occlusion. And at the end, when you pull, yeah, you see a good blood return, then you successfully unclog the little blockage there. Okay, if all these fail, then you might need to consider whether to discuss with the doctor, whether want to order any thrombolytic therapy, such as urokinase. But of course, you need to further dilute the urokinase until like 5,000 units, and then you only inject in for 2 to 3 ml is sufficient. Okay, we are not intend to give IV the thrombolytic. Okay, we are our intention is just to dissolve the clot in the catheter. Okay. So far, am I too fast? Okay. I would like to chat with you, or some of you see your senior or your colleague asking the patient moving, or even some of you follow the same, asking the patient moving the head, the chest, the neck, turning, standing up, coughing. Do you know what is the reason for the point number 2? Anyone can try. You can type in the chat box, or you can unmute yourself. Why you want to try to repositioning the patient when occlusion happen? Anyone would like to try? Do you know why you're asking the patient moving up and down, turning left and right?
To dislodge the clot.
A lot people guess that could be the reason.
Okay,
Actually,
more to
oh, very
oh,
good.
clever.
Who is this? Clever. Emmeline. Emmeline, are you one of my ex-students? Your name, Pang. Very familiar. Okay.
pinch off syndrome.
Yes, okay. Hello, Emmeline. Your name got 2 M, right? So these are my students. If you forget the reason, then I'm going to rotan you. All right. So, yeah, clever. So thanks. I'm glad that you still remember what you learned. And yes, this is pinch off to rule out, okay, pinch off syndrome. Okay, because it could be no backflow condition. It could due to pinch off syndrome, but not because of blockage or occlusion. Therefore, we want to rule out: is it due to pinch off syndrome or is it an occlusion? Okay. If you look at this one, you see, this is what it means: pinch off syndrome. Can you see the cartoon moving? Okay. So pinch off syndrome is occur when the catheter implanted, because they are all central venous catheter, right? Some of the method or the way the surgeon or the doctor implant the catheter, they travel through the subclavian vein, but is placed too medially. So the catheter become trapped in the ligament between the clavicle and the first rib. The shielding motion of the ligament gradually, sometimes even it will fracture the catheter and cause catheter damage if this is severe. But obviously, as you see in the cartoon, this will cause the pinch off. Okay, so it will like you're unable to aspirate blood backflow or push in sunlight. But when you ask the patient to move the shoulder, turn the neck, and while moving with this different position and angle, then you're able to suck blood and push in sunlight, and then you can for sure this is due to pinch off syndrome but not occlusion. Okay. So we completed one common complication, which is occlusion, right? So let's move to catheter damage. Catheter damage could be visible at the external part, especially those CVAD where you got tangling catheter outside, like PICC, tunneled and non-tunneled catheter. But don't forget, catheter damage also could happen to our chemopod. Although we got a pod, but don't forget the pod also got a long catheter underneath your subcutaneous layer, and also will go into your central vein and the tip reaching the superior vena cava, right? So catheter damage can happen to any CVAD. If you visible and external part is easier to detect. The most worried and dangerous part is the damage is in the part that already implanted in the patient body, okay? Especially those tunneled under the subcutaneous or what. What if the drug leaks out from this damaged catheter or cracked catheter? And what if the drug is a vesicant agent? Then you can cause severe extravasation, okay? So what are the signs and symptoms of catheter damage? one of the symptom is unable to aspirate blood. Okay, because just like when you want to drink from a straw where some of the straw got crack. Okay, when you suck from a cracked or damaged straw, you will realize you keep on sucking the air or whatever, but you're unable to suck out the drinks, right? So this is similar. If your catheter is cracked, you were unable to aspirate the blood from the tip of the catheter from your central venous. You were unable to aspirate out blood. So a lot of people assume, so assuming is very dangerous. So a lot of people assume when you're unable to aspirate out blood, it's due to occlusion. And then you can push and push the fluid in. And what if you're unable to aspirate? But you see, if the cracked catheter, do you think you can push it? I believe yes, certain amount, okay? Especially patient with the tunnel catheter, okay? So whatever you push in is just like leaking into the subcutaneous layer. So if the amount is 5 mils, 10 mils, 20 mils, if the patient got some thicker layer of fat tissue, then actually you are giving an amount of medicine under the skin instead of intravenous. So what if the drugs that you push in is a vesicant agent, then you'll cause extravasation. So that's why the warning is never push in any drugs if you're unable to aspirate blood. And do not assume that when you're unable to aspirate blood backflow is always due to blockage. No, because damaged catheter also can lead to unable to aspirate blood. So do not push in anything if you're unable to aspirate blood, and do not assume, okay? And if it's the external part of the catheter which damaged, of course, you can see leakage, you can see wetness of the dressing, okay? And yeah, you can examine and find unexplained fluid under the dressing or along the external part of the catheter if the damage at the external part. And sometimes you also find some white powder around or outside your catheter. This is, you did not realize the leakage, you did not realize the wetness, and the white powder is the dry off chemotherapy. Okay, so this you can suspect that might be some leakage or damage of the catheter. Okay, and of course the most obvious, this is separation of the connector from the pot. Okay, look at this one. If you look at this little cartoon at the bottom, you see when there's a chemo pot and you got a connect. Can you see my mouse, Dr. Becky? Yeah, can, good, great. So this is the connector part. Okay, when they fix the chemo pot, it must click well. Okay, sometimes it did not fix well, or it loose, or due to forceful pressure, then it dislodged, or yeah, then it got some damage, then it will leaks. Okay, or it dislodged, it will leaks. Okay, and you look at this picture. This is the extravasation that already happened. Yep. As this is due to the, could be a dislodged pot, or it could be due to that catheter damage, and you still assume it's a blockage because you're unable to suck blood backflow, but you're able to push in your saline. Then some doctor assume it's a blockage. Or partial blockage, okay, cannot suck. It could be due to a blood clot that flapping at the tip. They're assuming, you see. So you're unable to suck, but you're able to push. Then you proceed with a vesicant agent, and this is the outcome. Okay, extravasation. So always, okay, the extravasation could be a result of catheter rupture or pot leakage. The pot leakage also might due to you did not use a proper needle, such as non-coring needle. In section 1, I already highlight how important a non-coring needle, so that you can preserve the condition of the septum of your pot Yeah, if you use coring needle, then the septum of your pot will be keep on core by your needle and it will leaks. Okay, and yeah, and also the incorrect needle length. Incorrect means not long enough. Maybe the patient is a bit fat, the fat layer a bit thick on top of the pot, yeah, such as this cartoon, right? You saw the fat layer and the skin. So your needle must long enough. Sometimes if the needle not long enough, that it did not really go till the end and well secure there, or it only still at the fat layer, then you assume already in, so you're going to start infuse, that it leaks out at the side. Okay, so you have to aim to the back of the pot septum. Your needle should feel the metallic click upon the needle insertion. Okay, you feel that, I'm touching the base. I can feel the metallic base. Okay, and then you must, this is, I repeat, must use the non-coring needle. Do not use the normal coring needle. Yeah, so this all can prevent extravasation. Other tips to prevent the damage of catheter, come back to damage of catheter, is never use excessive pressure forcefully when you flush the catheter. If you find resistance, do not force and squeeze or push in whatever saline in the syringe, because you are ballooning your catheter, okay? When you push it in, you like ballooning and it can burst and crack the catheter, okay? And another important point is you must use syringe for all the CVAD 10 cc or bigger, okay? Do not use syringe smaller than 10 mils. Because the smaller the needle, it will create the higher the pressure, and the high pressures will crack the needle, okay? The catheter, okay? High pressure might crack the catheter. Do not push forcefully. Do not start vesicant agent if you are unable to aspirate blood, okay? Do not assume it's due to blockage. It could be due to damaged catheter. So please do not start vesicant agent if you're unable to aspirate blood backflow. Avoid sharp object. This is especially those CVAD where you've got external part, like your PICC, your tunnel and non-tunnel line. So please avoid sharp object. I encounter some of my junior nurse, they're difficult to remove the micropore or whatever that previously they stick on. They go and use a scissors to try to remove the micropore. At the end, they cut the catheter. Okay, so be careful with sharp object and avoid kinking of the catheter. Okay, I understand you like to make a U loop and stick nicely, but do not kink with the U loop. Please make it really a U and big U, okay? Do not make a V where you kink the catheter. When you frequently kink the catheter in you know, some CVAD you can keep for months and up to a year, right? If you frequently kink the same part, then it will crack the catheter, it will damage the catheter. So these are some prevention tips. Okay, if you ask me troubleshooting, too bad. If your catheter already damaged, if some products, and if it's an external part, some can be repaired, just the part, okay? That's the troubleshooting. Repair the parts that's damaged, okay? If it's an external part that torn. But if it's internal part, too bad, you really have to remove the catheter, right? Have to change a new catheter. Change a new CVAD. So there's no troubleshooting for CVAD catheter damage if internal damage. So please prevent damaged catheter. Infection. So infection, it could be just the insertion part or puncture part of the CVAD. Okay, can be just the catheter insertion site of the CVAD that has been infected, or the port site, the needle puncturing site. Okay, so the sign of infection to your CVAD puncturing or port site are You can observe from the skin redness, tenderness or pain, warm to touch, cellulitis, or can spread in a diffuse circular pattern into the surrounding subcutaneous tissue, or purulent exudates or induration. Okay, these are the puncture site or the pot site. How to prevent? Infection always can be prevented by your good aseptic technique and aseptic non-touch technique for site care and dressing changes. Yeah, and the dressing, please use a occlusive or transparent dressing, okay, so that you can monitor time to time and maintain the dressing in good condition, well stick, okay, and dry. If it's not due for dressing change, but you can see the dressing is not intact and it is already wet, please do the PRN dressing, okay? Regular access review and assess for all the early warning sign of infection, and advise the patient to report any concerns straight away. Use the 24 hours contact number. That it would be good that if your organization provide a patient who to call if anything goes wrong with your CVAD, okay? And if you are putting in the chemopod needle, the non-coring needle, okay, you have to replace the needle according to the instruction. So different type of needle got different length that you can keep it, right? So especially non-coring needle, those that without extension, without clamp, you only can keep for 24 hours. So non-coring needle that with extension and clamp, you can keep up to 7 days. So make sure every 7 days you change a new needle, okay, if your patient is admitted for months. Troubleshooting, what if infection already happened? Okay, you can see redness, discharge, pus, everything. Of course, you have to refer to the consultant, the clinician, okay, and can obtain exit site swab to determine or see what are the culture and sensitivity result. Then the doctor can prescribe the antibiotic therapy accordingly to the CNS result. And why, if patient on chemotherapy, why we need to obtain the full blood count? This is to rule out, is it because the patient post chemotherapy and the patient is experiencing neutropenic. If the patient is very low blood count, that leads to high risk of infection, okay, and might want to give some booster to boost out the immune system, okay, so that the infection can be treated easier. If appropriate, treat with antibiotic drugs. But if this fail, that means you try all the troubleshooting, try all the antibiotic or whatever, and the infection still did not settle, then the catheter and pot should be removed. So what a waste, right? So if you spend few thousand to put in a CVAD due to infection, the infection is due to our poor handling or we are not practicing the aseptic technique or whatever, then you lead to the patient have to remove the CVAD. So it's not very good. Yeah, you waste patients' money and go through all this difficult. Yeah. Another type of infection is not just the exit site or the pot site or puncturing site. The other type of infection that could happen to CVAD related is catheter related bloodstream infection. Okay, what's the difference? This one you can identify with this following sign and symptom is whenever you attempt to use the CVAD, whenever you flush just saline or whatever, after 5 minutes, 10 minutes, the patient who come to you with a very good general condition, but after you suck and flush saline or take blood sample and then flush with saline, then the patient suddenly turn fever, chills, shaking, rigor, temperature shoot up to 38, 39, 40s, yeah, then you need to suspect this is catheter-related bloodstream infection already. Okay, and others like it could also, you might also observe redness, drainage, or swelling of the exit site. The other symptoms like fatigue, malaise, acute altered mental states, confused, high fever, okay, tachycardia, hypotension, is a bit like septicemia sign, right? But this is due to catheter-related bloodstream infection. Okay, how to prevent? Again, this is due to the infection already in the catheter. Okay, inside the catheter line, got infection or microorganism growing in the catheter line. Whenever you flush, then it will cause the sign symptom like septicemia. So to prevent this happen, again, prevent infection that can sit inside, like effective hand washing prior or to any dressing change, any manipulation, flushing, dressing, putting in needle, off needle. So please perform effective hand washing. Clean the injection pot or injectable bung, whatever CVAD you use, with your chlorhexidine or your alcohol swab, and make sure you clean properly, thoroughly, and allow 30-second contact time. Okay, do not just immediately swab and immediately inject the rubber band. You do not allow sufficient contact time for your chemical to be effective to kill off the microbe at the rubber band or on the skin surface before you put in the non-pouring needle into the pot. Okay, the 30-second contact time is crucial. And minimize the frequency of CVAD is assessed, okay, if unnecessary. Okay, do not frequently go and use or touch the CVAD. If you do not require it, please do not increase the frequency of infection risk exposure. Ensure the individual assessing the CVAD is adequately trained. That's why for those who not non-post-basic oncology nursing trained, or you need to be a proper privileging a process where you have to go through some training, some demo, written demo, practical, first assessment, second assessment with 80% scoring above, then only your organization privileging committee will endorse and privilege you that yes, you can start handling all this CVAD, okay? What if the catheter bloodstream infection already happened, that all the signs and symptoms that you detect? Okay. So now you have to obtain blood culture. Why some doctor ask you to take blood CNS from the peripheral brachial line, okay, brachial vein, and also take from your CVAD, okay? You might having question mark, already take blood CNS from CVAD, why need to again venopuncture the patient from the brachial vein? Because sometimes the doctor want to have a comparison. Is this septicemia condition due to the catheter related or non-catheter related? Maybe the patient got this septicemia due to other condition, other source of infection. Okay, so when the doctor order blood CNS from the central line and concurrently order blood CNS from peripheral line, then if both positive, then it could be from the CVAD. But sometimes the CVAD negative, but the peripheral one is positive, then it's not due to the CVAD. Okay. And again, I repeat, when taking blood culture from CVAD, do not discard the initial blood sample. Okay. Then obtain septic screen specimen, administer IV antibiotic as prescribed. If thrombus-related infection, then consider anticoagulant therapy concurrent with antibiotics. Okay. And if the patient remains symptomatic 24 to 48 hours after your high dose antibiotic, all the things that you try to do, okay, and you cannot settle, then consider removing the CVAD following discussion with microbiologist and the clinician. Yeah, so end up you have to remove the CVAD. Okay, next. How much time I still have? Okay, quite good. Okay, so air embolism. Air embolism is because this is central line, they are big catheter, right? So be careful when you infuse any infusion. Do not allow air to go in upon completion of your infusion or in between of your infusion, or even from your syringe. Please make sure you remove all the bubble in your syringe, or sometimes it's dislodged of the stopper and you did not clamp the catheter properly. So all are the possibility that how you allow air enter into your CVAD and your air start to travel in your bloodstream. Okay, what are the signs and symptoms when air embolism already occur? The patient might have symptoms like hypoxia, confusion, hypotension, pallor, tachycardia, anxiety, chest pain, tachypnea, and unresponsiveness. Okay, it depends on where at the end the air embolism block happened. It could be at the heart, at the brain. Okay, so how to prevent? Like just now I listed out all the possibility of causing air embolism, right? So please use Leo lock connectors for all your CVAD. Yeah, do not use as like if you connect to IV infusions, IV set, okay? Then some infusion set are the slip head, okay? They slip into your catheter. Some is Leo lock, okay? So please, the preferred type is choose the Leo lock. Infusion set, catheter, syringe stopper, please choose Leo lock connector. This will have a better secure. And if an open-ended CVAD, please ensure the external clamp is closed all the time, okay? When you're removing the stopper. So whenever you remove stopper, make sure that it's clamped. If you remove stopper and it's unclamped, then there's opportunity that the air start entering into your central venous catheter and then start travel in your bloodstream. Some might use a chemo pot needle without a clamp. That's because I mentioned some chemo pot needle come without a clamp, without even extension catheter, right? So if you're using chemo pot needle, you insert into the pot and there's no clamp, but you need to disconnect your syringe and connect to a bunk. The split second, sometimes you can advise the patient to apply the Valsalva maneuver. That means you ask the patient to pinch the nose through, okay, and then close the mouth and try to blow like you forcing air coming out from the ear, okay? So while the patient performing that Valsalva maneuver, then you disconnect your needle and straight away connect the stopper. If you are using chemo pot needle come without extension and clamp, okay? You have to, make sure you prime all your CVAD or your tubing, your infusion, everything. Make sure no air bubble well before you insert or connect to your CVAD. Okay, what if air embolism already happened presented with all the signs and symptoms that I listed just now that you suspect, or you realize or you identify a certain amount of air already travel in your line and already enter the patient body, but you're unable to stop it and it's too late and you observe that already went in. So you have to immediately respond and do something. If not, the air will start travel and when the little air bubbles start traveling and then they accumulate, become bigger bubble and bigger bubble. And if from a big blood vessel, they travel and go to a tinier capillary or blood vessel, reaching the heart, reaching the brain, then it will cause like occlusion condition to your heart or brain. So you need to act fast because you don't want the air bubble to travel to the heart or the brain, right? So you have to, as a nurse, what we can do is immediately turn the patient to the left side and put the patient at translumbral position, so that hopefully you can trap the air. When you lie the patient in this position, then the leg is higher than the heart and the brain. And air usually is at the, they are lighter and they are will be at the higher level, okay? So you try to hold the air embolism at the foot of the patient and immediately notify the clinician. Okay, subsequently, what the clinician might order, they might order the high dose oxygen therapy. Then we need to continue monitor the vital sign, and we need to document the incident. Of course, there are more invasive intervention that the clinician might order and they might perform. Okay, but as a nurse, these are the few things that we can support the clinician and take care of our patient. Okay. Thrombosis. Thrombosis is the blood occlusion to the vein. Okay, is similar as something similar, or you can imagine like a deep vein thrombosis. But this thrombosis happen is because your catheter is in there. Okay, and the thrombosis happen is the blood clot is outside because your catheter is there, and outside the catheter, the clots stuck there. All right, so it cause thrombosis to your the vein. Okay, it's occlusion. The flow of your vein, your blood return is being occluded. So this could due to one of the complications of CVAD. Yeah, because you got a long line catheter in your vein. So what you can observe, what you might observe when thrombosis happen due to your catheter got thrombosis externally and occlude the vein return, the flow, you can see edema of arm, shoulder, or of neck or face, the standard arm or neck veins, bleeding at the exit site if you are having like a PICC sites, okay? Then the puncture site of the PICC, you might have some bleeding because the back is, the blood like pressure in the arm is high, they're unable to return back to the systemic, okay? You might observe discoloration of the arm or synostosis and pain in the shoulder. Okay, this is a deep, like a vein thrombosis already, okay? And it might develop of collateral circulation. How to prevent? Okay, some thrombosis is happen because while insertion, there's a lot of traumatic or injury. So that's why they already like internal injured the lumen of the vein. Okay, so the prevention is first non-traumatic insertion and catheter advancement. Diluting, irritating, or sclerosing agent. Okay, so you won't damage the internal lumen of your vein, and then high risk to have like stuck with all these could be clot, could be all the cholesterol or anything. Maintain good fluid balance with adequate hydration so that your blood won't be too thick. Okay, so good hydration. Then to dilute further your blood, okay, and whatever drugs that enter. Encourage normal movement of extremities, okay, movement, exercise, activities, encourage blood circulation. What if thrombosis happen? Okay. If venous thrombosis is suspected, then have to discuss with radiologist and confirm with venous ultrasound scan. And if confirmed, then the doctor have to commence anticoagulant therapy to declot it, okay, to remove the thrombosis. If patient is symptomatic and alternative IV access is available, sometimes and you're unable to declot or remove the thrombus, then it will end up remove the CVAD. If the patient is symptomatic but has no other IV access, then they need to like have further discussion with radiologists and what other method can be used to remove the thrombus. Okay. Number 6, catheter tip migration. Okay, this is commonly happen to PICC. And what you can observe, the sign and symptom are increased length of the external catheter, okay, getting longer and longer each time you access, and lack of blood return, because you can imagine the tip is getting further and further from the central venous. Swelling in the chest or neck during infusion. This could be the tip is no longer at the central venous, but at your some other part of the vein, but not the central. The patient might complain of pain or discomfort during infusion. Leaking at the catheter site, exit site, sensation in the neck during flushing, like the ear gurgling. Okay. And some even complain of chest pain. So these are some signs and symptoms that you might want to suspect catheter tip migration. Okay, and difficulty in aspirating blood, inability or difficulty infusing fluids via the catheter. Prevention: secure the catheter with suture. Okay, but if the suture is no longer there, then please replace with a stat lock, and also add on with a semi-occlusive dressing. So all this is for better secure of your PICC. If not, it might due to activity or patient movement or patient go home and changing clothes or whatever, they might accidentally pull the catheter. Okay, maybe they got children around them. Okay, so you must make sure it's well secured. The plaster is there, the stat lock is there, or the suture is there. Okay. Follow procedure for correct dressing technique. So whenever you remove the dressing, changing of stat lock or cleaning the surrounding, please be gentle. Okay. You may leave the catheter, but please do not accidentally pull the catheter. Troubleshooting: what if it's already happened and you observe it's getting longer and longer? If migration or malpositioning is suspected, then we refer for a chest X-ray to ensure the tip of the catheter is still at the superior vena cava, okay? The atrial cava junction, right? So if unsatisfactory position, then can refer to radiology for guidance on whether the catheter can be replaced over a gut wire. Sometimes it still can can be rescued, okay? And this depends on how bad it happened or how long it been pulled out, or then let the radiology to evaluate. Is it possible to replace or not possible? If unable to reposition over a gut wire, then too bad. You really have to remove the CVAD. Okay. This is some additional situation that I would like to share. Some of you might encounter dehisced port. Okay, you can see like the skin is getting thinner and thinner, and part of the port already been exposed. Of course, this can happen if there's infection there. Then your skin condition, you got pus there, of course, can due to infection, then due to the skin condition or is not healthy anymore, you can have dehisced port. But however, dehisced port also might happen even though there's no infection and it's not nurse's fault. It's due to the pocket site. Okay, maybe the site that choose to implant the pot, it is not appropriate. Too many movement, or maybe the skin is too thin, the fat is not sufficient, you see, and the position or location with on top some bony prominence, it is a wrong site. It could due to a wrong site. Okay. And this pot also might due to is insufficient depth when you implant the pot. Okay, the you is the person who implant the pot, the person who choose the location of the pot. Okay, and the pocket size. When you implant the pot, the person who implant and want to put in the pot must have to create a pocket, okay, underneath the skin and the subcutaneous layer. So the pocket size must appropriate size, okay, deep enough. Okay, so if it's not correctly done, appropriately done, then it might end up with the his pot. Okay. And also, it might also due to the patient healing properties, immunodeficiency, okay? And all these could lead to this situation. Okay, lastly, okay, 5 more minutes. Mechanical fibrillatiss. I think this is the very common that you can observe, like erythema along the vein, pain, palpable venous cord, heat, all the inflammation signs and symptoms like swelling, stiffness when strengthening the arm. Okay, how to prevent? You can apply the prophylactic heat to the upper arm. Okay, some warm compress. Okay, 4 times daily, about 15 minutes. Okay, for 3 days post insertion. Sometimes this fibrillatiss is due to the because all the traumatic when you're putting in the PICC or whatever, it causes all the inflammation. So we give a try first with all these warm compress. We see 3 days after post insertion is subside or not. Okay, it should be another advice to prevent all these fibrillatiss is please be gentle gradually during the catheter insertion. Of course, we don't want this fibrillatiss is due to infection. So please maintain aseptic techniques. Okay? If it's already happened, we exclude infection first of all. If the fibrillatiss is it due to infection or not? Okay, then we can check patient fever or not, or we can take some culture and sensitivity to the exudate at the exit site. If it's not due to infection, it's just due to trauma or inflammation. Again, we try the warm compress first, okay, and consider non-steroidal anti-inflammatory medication unless it's contraindicated. And mechanical fibrillatiss should subside within about 2 to 3 days. Okay, I think I cover those complications that I listed. Okay, nice time. So any question?
Okay, very comprehensive. I have a question. You mentioned that this air embolism can cause like a lot of things, but actually this is venous, right?
Yes.
Yes, but if you say like a stroke, it must go to the other side where it's the arteries. So unless the patient has a perforated,
that's why we don't want the air embolism travel back to the heart and then go out via artery.
Wow, the air embolism must be very big to do that.
That's why, because you are handling CVAD. CVAD is a big line, and all this big line, whatever you infuse, it go into your central venous.
I see.
Yeah. So the catheter are all big lumen, whatever you infuse. Like sometimes when they infuse the first drug A, and then they allow, it shouldn't, but it happened, they allow the drug A dry, and A started to travel following the central venous catheter and infuse in. You
I
see?
see.
Then it travel in the bloodstream and it can then pump up from the heart again. So because it entered the heart, very dangerous.
I see. I think it is very possible because, but it is more likely to be pulmonary embolism more than stroke because it's over the left side. So let's say the catheter goes into your right atrium, okay, the air embolism, it will go to pulmonary artery. If from pulmonary artery, okay, then
Could
only
be.
it will go to pulmonary vein and then, you know, so
Yep.
it's a bit odd. Okay, so we go on. Any questions at all? Okay, please, you can actually unmute to ask the questions, or you can put it in the group chat if you're shy. I think it was a very good talk. The timing was amazing. And this actually conclude the two segment of management of CVAD, right?
Yeah, the care. Yeah.
Yes.
No question in the chat box, I think.
Nothing at all. Okay.
Is it too fast?
I think
You all understand?
okay, because I think it's also because it is very specific to oncology. Maybe some of them are quite.
Not necessary. It's just that any cases that using central venous device. Yeah.
Okay. So there no questions at all, guys. Let me check Facebook. I forgot to check Facebook. So actually, sorry, no. Okay, so I think, okay, June says, thank you. The session is very informative and clear. Yeah, I think it's because it's very clear.
Okay, at least some response and not that they
Yeah.
they don't understand.
No, of course. I don't think it's unlikely that they don't understand. Because
great.
yes, it's unlikely that they don't understand because everything was stated point, you know, in a point form, and the pictures were all very
because there are a lot correlated with the first session, you see. A lot like a carry from first session. So I worried some of them did not attend the first session, that they cannot follow. Some need prerequisite from first session. Do you realize?
Okay. Okay, so there is a question now. There are two actually. MC Yip asks, how about if no blood backflow but smoothly flushing? No any complaints, can it still be used?
If me, I don't dare to use, because what are you assuming? Are you assuming it's due to partially blocked? Could be a blood flat at the tip. That's why when you suck, then it block, cannot suck that flow, but you push it smoothly. Or it could be due to catheter damage. It could be due to some internal part dislodge. I do not know, because we do not know. We do not have X-ray eyes, you see. But if you take the risk and you assume it's due to partial block and you want to proceed using it, you have to check first who give this instruction to proceed even though no backflow. Because the guidelines, the principle of using CVAD is no blood flow, you shouldn't proceed. But some patient, every cycle come to you also no backflow, and if the doctor give you the instruction, we proceed, then please document it down, because you are violating the principle with some instruction given. Please document it down, but I don't advise to proceed. But yes, we will go for further investigation. What is the root cause of unable to suck backflow? Okay, of course, you try all the troubleshooting, like all the steps that I share, the rule out the pinch off syndrome. You try all the popping mechanism, push mechanism, flush with try with saline only, but do not proceed with your medication, right? But after trying all this, and if you proceed with X-ray with contrast and proven that there's no leakage, no damage, and then the drug still come up from the tip of the catheter, just that unable to suck backflow, then if you feel safe, and of course with the consultant and the doctors feel, the minimum risk, we can proceed with chemo and extravasation, please document down all this attempt been done, investigation done, X-ray done, no crack, no leaks, and we proceed with chemotherapy or vesicle agent. If at the end something happened, at least you got all this proper documentation, you already do your best, do the part, okay? So that's my advice lah.
Okay, Ching Ying asks, may I know if there's no blood return to all the chemo, or is it
able to flush?
Is it? Oh, it's the same, huh? It's better to do an X-ray. Because at our place, we sometimes doctor just ask to proceed. Yes, so
I think the same answer.
The question is very well answered. Yes. So yes, if the doctor says, then you document it down.
Yes. Sometimes you can take the risk, or this also depends on what drugs you're putting in. Yeah, especially vesicle agent, the risk is higher. We really have to think twice. Yeah. But if just normal saline or whatever, if it's at the end not into the vein but into subcutaneous or whatever, the damage and the risk is not that high, you see. So we have to evaluate the risk as well.
It's a very difficult decision, if you can put in and cannot withdraw blood, because yes, very difficult decision actually. Not to not proceed.
Yes, this is always the common question. Even the doctor also in difficult situation. If every time no backflow, every 3 weeks you want to order a chest X-ray, it's also a question mark to the doctor. I also understand and pity.
Do you extract the whole thing out? It's not a position I would like to explain to the patient.
Yes. Therefore,
even the patient may say, please go ahead.
Yes, but of course the patient do not know the risk behind it, but we know. But we also in difficult situation, proceed, not to proceed. The doctor also to order X-ray every 3 weeks, every cycle of chemo, I don't think is practical as well. So they are also taking the risk. So the nurses is a bit safer because they're taking instruction from the doctor who taking the risk, but the nurses, at least we please document it now. The risk is taken by the doctor. Very bad, huh?
Yes, but no choice.
No choice.
Yes, because you have to safeguard yourself. That's one. Two is really, I don't use any of those, but to say that you take X-ray every 3 weeks, but still your decision is still same, okay, go ahead, means you take X-ray, okay, and then you say go ahead. What you are just practicing kind of defensive medicine. I think it is a very difficult decision, a very good question also. Yeah, so I think with that we will end our session here. Okay, we'll just stop recording.